Kinda now. Good morning to everyone. I'm a assistant professor in the critical care nursing department from the International Islamic University, Malaysia. So today I would like to present about the title is the preserving of confidentiality in emergency medical services. Scoping review findings I would like to present in here. So I start the presentation. I will take about my presentation around 10 minutes. If you have any question, you can ask at the end of my presentation. These are the today presentation outlines. I would like to focus about what is the EMS, and then what happening in this at the moment, and then the purpose of this scoping review, and what methodology I use for this scoping review, and then what is the findings of this scoping reviews, and how this finding can be applied in the real settings, and then what the recommendation for the future researcher or future. So, and then some references for this presentation. Firstly, what about EMS? No, emergency medical services is a very crucial role in our healthcare system in each and every of the country. So, in that emergency medical services, emergency medical services personnel are always deal with the stress situation, and then always handle and then the patients with the life-threatening situations. So in this situation, the patient confidentiality, the information sharing is very important and then very cornerstone and then fundamental role of the medical ethics of our profession. That's why we need to think about what about ethical confidentiality in the EMS setting. So those are my introduction, and then the motivation. I want to know what is the role of the confidentiality in EMS setting, and what are the challenges is happening now, and then how we can maintain or how we can control these challenges or overcome these challenges. That's why I start the scoping review. So these are my background of the scoping reviews. First is what is the role of the confidentiality in the emergency medical services in setting? So as I mentioned earlier, we are very difficulty to handle, and we always conflict between the information sharing and patient privacy, always happening in the emergency setting. And then also another corner is the medical ethic. There is a very principles and very fundamental in the healthcare system. So how we can do the balance, and then what are the have to control the transparency of the data and how data management. So these are the query, and these are the background of my scoping review. If we control, or if we a little bit high strengthening the confidentiality in EMS setting, maybe public, we get the trust from the public, and then this trust and then open communication also can be effective in the diagnosis and treatment of our emergency services setting. So those are the role of the confidentiality in EMS setting. Another background is what about challenges of this confidentiality? So as I mentioned earlier, we accept the patients who are life-threatening situations from the pre-hospital to our setting. So that time we need to deal with every various parties. For example, specialists, we have to collaborate, and we also get the patient information from bystanders. So these are how much we can control of the patient data and patient privacy. So those are the challenges. So these are one of the background of my scoping review. That's why if we study about the scoping review about this issue, we can be based on this scoping review result, we can do something knowledge where is a gap, and then how to overcome. So that's why we start the scoping review. So the purpose of the scoping review is to identify an existing knowledge that can identify the areas where knowledge is lacking and identify possible path for future research. So in that, another purpose of this scoping is I want to highlight we want to highlight the best practice. So what is the best practice to control the patient privacy and information, patient data? These are the one of the purpose of the scoping review. So proceed. The next slide is how we are doing the scoping review. We are based on the use of the Prisma SCR framework for this scoping review. We use the 3 databases such as the PAGMA, Scopus, and Google Scholar, and we use the search term is the EMS, Emergency Medical Services, Confidentiality, Ethics, and Ethical Consideration. And in that situation, we use a Boolean operator. It means that we use and or. For example, EMS or Emergency Medical Services and confidentiality or ethics or ethical consideration. So based on this guideline, and then we set up the inclusion criteria for our scoping review, the year limited, since the start from 2018 to 2023, and then all paper must be written in English, and then related with the empirical research or review paper, related with ethical concern in EMS and confidentiality, because we want to narrow down and we want to focus only the confidentiality in the EMS setting. We exclude the paper which are not written in the English and then which are not related with the ethical. So these are the such criteria and concept. We narrow down the keyword and to find out the relevant records, relevant reports, and relevant articles. So you can see in here, this is a Prisma SCR framework. First, we identify based on inclusion criteria, we have a records of the 334. After that, we screen it and we eligible is at the end of our scoping review based on the quality assurance. We only got the articles for this scoping review is there only 16 articles involved in this scoping reviews. So these are the sample of the extracted data from our scoping review. So what about data analysis of the scoping review? We go to the 4 step. First is the immersion. Immersion means that we got the 16 papers just now, and then we extract the data based on the, just as I mentioned the previous slides, based on the extracted data. This is called immersion. After immersion, we read, and then because we have 2 reviewers, so we do ourselves. After that, we merge what is the coding, and then sub-themes and themes. After that, we write the narrative synthesis. We combine, and after that, we find in the report. So the findings of our scoping reviews, we got the 3 main things regarding with the ethical confidentiality in EMS setting. First is the supported legal and ethical framework. The second is the patient privacy and dignity. The third main thing is the practical challenges is EMS settings. So in here, I would like to elaborate a little bit more about the each main thing. First is the supporting a legal ethical framework is very important, and then various framework all over the world, because based on their healthcare system and based on their cultural complexities and based on their regulation bodies. That's why every country have a bed. We have to align with the WHO, and then we have to align with our culture of that country. For example, in Malaysia, we have a Malaysian Medical Council and Ministry of Health. They control and they establish the ethical privacy for EMS, Emergency Medical Services in Malaysia. They have a framework. After this framework, they establish and they build up the act. This act is a PDPA, Personal Data Protective Act. So we have a personal data protected act. We have to follow this act. After that, why giving the services in the emergency setting in Malaysia? This is examples of the supported legal or ethical framework is very important in the emergency setting to control the patient confidentiality. Next thing is the patient privacy and dignity. Because this one is interrelated with the supported legal and legal and ethical frameworks. Because in Malaysia, PDPA, Personal Data Protection Act, is these are the patient privacy. With this act is to maintain the patient privacy and dignity. So that's why in Malaysia, setting is a supported legal ethical framework and patient privacy dignity is a interrelated. We have to align with this framework and we have to follow their regulations to preservation of the patient privacy and dignity in emergency setting. So this is the current experience in Malaysia. Maybe we will be sharing of the other country about that in the future. So next, the last thing from my scoping review is practical challenges. Although we are trying the best in the medical setting, emergency setting, but we are still struggling with the still trying to overcome the practical challenges. Why these practical challenges is happening based on the resources limited and then based on time limited. So emergency, we have to take care the patient and save the patient as soon as possible within 1 hour. So this is time limited. And then stressful situation, we always deal with the other parties. So those are the challenges. I saw the scoping review also, these challenges is happening. So these are my main key themes of our scoping reviews. So before I end the presentation, I would like to say, based on our scoping review, we have some implication in for our healthcare personnel, especially emergency medical services personnel. So we can highlight, based on this scoping review, we can highlight the importance of the confidentiality in emergency setting, and we should follow the relevant and related respected country of the ethical legal framework. And if we follow that way, we can give the patient-centered care and we respect our patient privacy and the ethics, so we can give the ethical care also. And then one more thing, based on this scoping review, highlight to us is don't forget the cultural contents of if you framework the ethical or legal framework for our emergency healthcare services, don't forget the cultural competency, cultural contents of that country or that people. So that's also we learn this based on this scoping reviews. At the end is the scoping review is point out us. We need continuous dialogue like this webinar and the semi-workshop in research and the collaboration with the other organizations and stakeholders. We need to refine and always improve our framework. Always update, not to give the effective ethical care for our patients in the emergency settings. So recommendation for the future researcher or future research, based on this scoping review findings, we got the knowledge and we got the light in our brain is regular training and instruction is very important for the emergency medical services professional in developing their ethical decision-making skills. And then also our policymakers, stakeholder must be involved and then actively involved, and also the cultural competency also have to imbue in the legal and ethical framework. And then also we need to upgrade, or we need to train, or we need to give the professional development for this emergency medical services via role play, simulation exercise, mobile app, and then during research and research finding presentations. So these are the recommendations for future based on our scoping reviews. So however, we have some limitations of the scoping reviews, this scoping review, because we only 16 paper involved, maybe a selection buyer, maybe, or also, and maybe the depth of our reading or our reviewing, maybe influence of our findings, might be influence of our finding. This is our limitations of this scoping reviews. So at the end of my presentation, I would like to give you and highlight and take notes to home is that I want to conclude like that. The emergency medical services ethical confidentiality is a very important and then multifaceted role. And then we need to train our healthcare personnel, especially emergency medical services personnel, always refresh their skill, how to balance between the confidentiality and information sharing. So that's are the take notes to home for you all or for the listener. So I think these are my references of this scoping reviews. So
my name is Irano Rashida and I'm pulmonologist from Ulin Hospital, Banjarmasin, South Borneo, at Indonesia. So good evening, everyone. I would like to share about pathological characteristics of fiber optic bronchoscopy procedure in Ulin General Hospital, Banjarmasin. Thank you for the opportunity. This is our publication, and we know that lung cancer is the second most significant cause of cancer-related mortality worldwide. There were 2.2 million new cases and 1.79 million deaths in 1990 and in 2020, and the most prevalent form of cancer and the primary reason for cancer-related fatalities in Indonesia is lung cancer. So flexible bronchoscopy is invented by Shigeto Ikeda in late 1960s, widely used for evaluating the endoluminal extension of cancer, and of course, tumor location and distribution determine the expected diagnostic outcomes of FOB. Sputum collection, bronchoalveolar lavage, aspiration, brushing, and biopsy was retrieve cellular material for diagnosing lung pathology. Respiratory tract cytology is well established as a critical diagnostic tool in the evaluation of pulmonary pathology worldwide. There has been no study on the pathological characteristic of FOB procedure in our hospital, and as our knowledge, this is the first study in Indonesia about the characteristic of the bowel aspiration, cytology, and brushing, and also for cytology from bronchoscopy procedure. The method from the study design is descriptive analytic, and data source is cytological and histopathological data from bronchoscopy procedure. And there were 117 samples grouped by gender, age, type of procedure, cytology, and histopathology finding. Malignancy determination, positive malignancy if cytology or histopathology show malignant cells, and negative if inflammatory or atypical cells obtained. And other malignancy is malignant cells that not origin from pulmonary. statistical analysis that we use were chi-square, and we do Fisher exact test if expected sample size was less than 5, with statistical significance p below than 0.05. And the study was approved by our local ethical board. This is our study result. This is the number of patients by year of bronchoscopic procedure from 2018 to 2020. There is 117 patients that positive result of malignancy were 79. And this is sample distribution of patient undergoing bronchoscopy. We can see that there were more male than female. And then with 79%. And then based on age, we can see there is in 51 to 60 odd years, there's a more dominant, and the procedure we divided, there is with forceps procedure and there is no forceps procedures. And this is the lung malignancy rate and demography characteristic. So we can see that although there is a lot of male than female, but based on statistical, there is no significant statistical result. And also in demography characteristic by age, there is no difference within the category of the age. So we can see this, the bronchoscopic procedure. We can see with forceps procedure, the positivity was 75%. We can see that without forceps, there is only 63.6%, but also the statistically not significant. And based on cytological and histopathology finding from bronchoscopy, we can see that the adenocarcinoma is the major of the malignant cell that we found in our hospital. This is, I think this is same with the region of Asia region. There is a lot of adenocarcinoma, and we can see that female, 50% of female adenocarcinoma. FOB revolution respiratory cytology, allowing collection of various samples like bronchial washing, brushing, lavage, and needle aspiration. In this study, 67.5% of 117 patients who underwent bronchoscopy had positive result for malignancy. And with the demographic finding in our study, there is 79.7% males and only 20.3% females, with ratio male to female were 4:1, and the 51 to 60 age group had the highest positivity rate, but there is no statistically significant relationship between lung malignancy rate and sex or age. Bronchoscopic procedures in our study revealed that 65.8% had bronchoscopy without endobronchial forceps biopsy, and the 34.2% had bronchoscopy with endobronchial forceps biopsy. We can see that the forceps biopsy had a higher positivity rate, but still not statistically significant relationship in our statistical procedure. The endobronchial biopsy is crucial for investigating lung cancer and has high diagnostic accuracy if enough samples are collected. And endobronchial needle aspiration, or EBNA, is a reliable technique to diagnose endobronchial lesion, especially when used in conjunction with endobronchial biopsy. Study from Mrudula et al. Said that bronchial biopsy discover more cases of lung malignancy than just only bronchial alveolar lavage, or just only bronchial brushing. So biopsy in this our study also, the forceps biopsy discover more cases of malignancy. And cytology techniques like bronchial brushing and washing are important for obtaining samples, with brushing more convenient and reliable than just the bronchoalveolar lavage or BAL. Combining multiple techniques like BAL, brushing, and biopsy can increase the overall diagnostic yield of bronchoscopy. In this study, combining all the BAL, brushing, and forceps biopsy, the detection rate of lung malignancy increased to 85.7%. And adenocarcinoma was the most common type of malignancy, followed by squamous cell carcinoma. And recent advances in bronchoscopy techniques improved the diagnostic accuracy and yield for detecting lung cancer. Endobronchial ultrasonography with guided seat like IBAS-GS, 86.4% diagnostic yield and 80% sensitivity for detecting peripheral pulmonary lesions. And virtual bronchoscopic navigation and radial probe endobronchial ultrasound will increase the diagnostic yield. The VBN diagnostic yield were 92% and IBAS at 81%. So in our study, we have a limitation include the retrospective data collection and lack of details on biopsy quantity and absence of radiology data. For conclusion, bronchoscopy is still an important instrument for identifying and discovering lung cancer. An endobronchial biopsy is crucial in examining lung cancer and can provide an accurate biopsy if enough samples are gathered for histopathological analysis. Forceps biopsy in bronchoscopy show a greater positivity rate than bronchoscopy without forceps, but no correlation between the type of procedure and the likelihood of malignancy was discovered in this study. But combining all of the procedure will increase the diagnostic yield. Thank you very much for your attention.
I would like to express my gratitude to the organizers. They have given me a platform to express my hard work. So my title was Assessment of a Planned Intervention Regarding Awareness of Danger Signs in Children under 5 years of age among mothers residing in a selected rural community of West Bengal. Mortality is the best indicator for social development and well-being over gross national product. And mortality and morbidity are the high among this age group, and they need regular health supervision throughout infancy and several years afterwards. In India, around 1.2 million under 5 children died due to preventable causes, likely pneumonia, diarrhea, sepsis, and malnutrition. According to UNICEF, 40% of all under 5 deaths occur globally within the first month of life, and many of deaths are related to late recognition of illness and subsequent delay in getting proper treatment. So purpose of this study is to make mothers aware regarding preventable death among under 5 children. I don't know what is happening, ma'am. It's not going. Sorry for the interruption.
Just give us a minute, please.
I don't know why it's happening. I'm sharing again, but keeping it in, not in. Ma'am, not keeping it slideshow.
Would you like us to share your presentation for you? And then every time you want to move on to the next slide, you can just say next.
Sorry?
Would you like us to share your presentation for you?
Sure, ma'am. Yes, ma'am, please. Please.
All right, thank you.
Sorry for the interruption again. Next slide, please. Quantitative approach and pre-test, post-test control group design has been used. Study setting is in rural area, and as a population, mother of under 5 children was my population who are residing under BPSC, Horiharpur BPSC. It's a name of BPSC, Block Public Health Center. And sample mothers who made the designated set of criteria and residing in randomly selected 12 sub-centers. Sampling technique, it was the composite multi-stage sampling technique, and sample size for pilot study, it was 60, and for final study, 240 each arm for study and control arm, total 480 sample size. Variables for independent variable teaching material, socio-demographic and socio-economic variables are there. And for dependent variable, knowledge of mothers regarding danger signs in children under 5 years of age and health-seeking behavior of those mothers whose children got ill. And data has been collected by interview method, by home-to-home visit, and intervention was given at sub-center or outreach camp with the help of laptop and projector. Data was analyzed by descriptive and using descriptive and inferential statistics. Next, please. This is my sampling technique. It was a composite multi-stage sampling technique. First one was purposely I have selected BPSC, Harihapur Block Primary Health Center, who has 48 sub-centers and 134 villages. These mothers residing there are my population. Then randomly I have selected 12 sub-centers from 48 sub-centers, and mother residing there are my accessible population. Now by randomized pair, by randomization by pair, I have gathered study arm and control arm sub-centers. Then from there, collected mother's name from maternal child health register, and by using Microsoft Excel function, sample size has been taken, 480 participants has been taken. Next, please. This was my tool and technique. The first tool was prepared to get background information of participant. It was a semi-structured interview, semi-structured tool, and interview has been done by home-to-home visit. And second one is to prepare to get back knowledge regarding danger signs in children under 5 years of age. It was a structured interview schedule, and obviously home-to-home visit has been done. And for getting health seeking behavior of mothers, it was a semi-structured interview schedule, and it has also been taken by home-to-home visit. Next, please. Tool has been validated by 9 subject experts, and content validity ratio was compiled and rearranged as per their expertise. Reliability of the tool was established by test-retest method. Ethical consideration, ethics committee permission has been taken before conducting the study, and administrative and also get administrative approval. And obviously, voluntary consent, informed consent was taken from participants. Then, next, please. Now coming to the result. As this table shows that participants characteristics of social demographic characteristics from control arm and study arm. It has been seen that almost significant one is from both group, mothers have been married before the age of 18 years, which is not acceptable actually. And parity and under 5 children, they have majority of mother from both group, majority of mother have under 5 children too, and they have parity less than equal to 2 or 2. Next, please. If we see the socioeconomic characteristics of participants, it's been seen that majority of mothers, that is above 30% of mothers from both group, have studied up to elementary education, that is up to class 5 to class 8. And majority of mothers, same mother, percentage of mother, 79.6% mothers from study arm, and 79.6% mothers from control arm were housewife, and the majority of mothers belong to the social class 4. It is a Biji Prasad scale, which is applied in rural area. Next, please. This table shows that utilization of healthcare services by both group of participants. It's been seen that above 50% of mothers from both group have visited antenatal clinic 4 times or more than 4 times. But it's significant that none of the mother, or above 50% of mother from both group, were not visited postnatal clinic. But, okay. Now, this table shows the knowledge on danger sign among participants. It's been seen that above 50% mothers from both group were aware of danger signs, and they told breathing difficulty is the first danger signs, followed by fever, severe dehydration, poor feeding, convulsion, malnutrition, coldness. But none of the mother have identified lethargy, infection, and anemia as a danger sign. Next, please. From baseline, it's been seen that as per knowledge score, both group is identical. There is no significant difference between groups. Next, please. This table shows after baseline data and after after 3 times intervention. At baseline, there was no significant difference between group study and control arm, but after each intervention at 3 level 1, level 2, level 3, after 3 intervention, it has been clearly saying that there is a significant difference found between 2 groups, between study arm and control arm. Next, please. This table shows that their health-seeking behavior of mothers at baseline. Above 80% of mothers or parents from both groups have decided what type of treatment has been sought. It's been seen that almost 60% and above mothers from both groups have seek treatment for non-medical, they seek non-medical treatment, and they do self-medication mainly, which is like they have used their previous experience to do self-medication, and they choose their place, the first place of treatment during illness of their children, as majority of mothers choose medical shop. From pharmacy, they used to take medicines and do self-care. And but for the time, they have gone for treatment after 48 hours of sign symptoms appearing. Next, please. This figure shows knowledge of mothers of study arm has improved after each intervention. It's been seen that as for breathing difficulty, it's a danger sign for breathing difficulty. At baseline, they have identified 49.6%. Mothers have identified it's a danger sign. But after third intervention, 91.81% mothers have identified breathing difficulty as a danger sign. And like those other danger signs, they have identified almost all are danger for their children. Next, please. This figure shows for control arm participants. It's obvious that after they have identified breathing difficulty and fever as a danger sign, but other danger signs, other 8 danger signs, they have not identified that much. Next, please. It's a health-seeking behavior after intervention. As per type of treatment, it's been association shown the type of treatment with socio-demographic profile of study arm participants. It's been seen that type of family, place of child delivery, parents' education, mother's occupation, and number of antenatal clinic visits has an important role in improvement of health-seeking behavior in terms of type of treatment. Next, please. It's also a health-seeking behavior in terms of time of treatment and association found with socio-demographic profile. For study arm, it's been seen that religion, pedity, and number of antenatal visits has an important role in improving health-seeking behavior. Now the major findings of my study. Both study and control arm, both study arm 41.7% and control arm 47.5%, mothers had not ever danger signs in children under 5 years of age at baseline. But after third intervention, this negativity reduced up to 0.9% for study arm and 14.5% for control arm mothers. Out of 10 enlisted danger signs, 3, that is lethargy, infection, and anemia, were not identified by any mothers from both arms, but after third intervention, only control arm mothers were not able to identify those, but study arm participants has been able to identify it. Next, please. Major findings in terms of health-seeking behavior. Most of most of the children, that is 65% children of study group and 59.58% from control group have got non-medical treatment during their illness at baseline. But after third intervention, practice to seek non-medical treatment for study arm group reduced to 28.9%, and for control arm, it has been reduced to 43.3%. Among non-medical treatment, study group used to seek consultation either from shopkeeper of medicine shop or self-medication as per previous experience, or from village doctor or from religious person. And for control group, it was 60.58%. But after third intervention, seeking non-medical treatment decreased to study arm more than control arm. Mothers of study group seek treatment after 48%. 59.2% mothers of study arm has been seek treatment after 48 hours of illness appearance, and for control group, it was 65.80%. But after third intervention, it has been improved for both group of mothers. Next, please. In discussion, we can say that present study shows baseline knowledge of mothers and where baseline knowledge of both participants of control arm and study arm were almost same, and there was no significant difference. But lethargy, coldness of body, and anemia was not identified by any mother at baseline, and which can reflect in another study which has been done in India, Bangladesh, and Ethiopia. And in this study, majority of mothers, respectively from study and control arm, preferred non-medical treatment as place of treatment. Majority of mothers taken help from medicine shop, and present study differs a study done in southwest Ethiopia, which shows majority, that is 83% of caregivers seek treatment from healthcare facilities, which is much higher than my study. Next, please. Here I can input one thing, as we have seen that control group mother also has improved their health-seeking behavior and knowledge, as because it may be the effect of COVID-19 pandemic situation. As my study duration was from 2018 to 2024 January. So my COVID-19 pandemic situation may have indirect effect on mothers. Now the limitations. Block was selected purposefully, which may restrict the external validity, as block was selected as it is my convenient for me to for intervention. Earlier slide, please, ma'am. Earlier slide. There was a chance of contamination among mothers of study and control arm if the selected subcenters are situated side by side village, and seeking the answer of same questions might induce some knowledge and behavioral change among participants belonging to the control arm. And presence of COVID-19 pandemic situation might induce care-seeking behavior to both arms, and only mother have been included and neglected other caregivers. Next, please. So I can conclude that early detection of signs, danger signs that harm neonates and children under 5 years of age is an important step towards improving their survival. Any delay in identification of those danger signs and subsequent delay in initiation of treatment means the child is more likely to die from the illness, and there is need for the mother to be able to identify those signs to avoid preventable death. The present study was undertaken to assess and improve mothers' awareness regarding danger signs in children under 5 years of age, which is fulfilled to some extent. Next, please. And for implication, early detection and timely intervention can reduce morbidity and mortality among this age group. So awareness can be empower mother to take appropriate action and in timely action. This study highlights parental education and access to antenatal care helps to improve awareness generation. So increased awareness within the community can foster a culture to health consciousness where community members reinforce each other's knowledge and behavior related to child's health. This finding can influence future intervention policies and programs aimed at improving child health outcome. Next, please. So I can recommend that repeated teaching program might have indeed an effect and might be taken up for awareness generation to mothers regarding identification of danger signs in children under 5 years of age. And same study can be replicated in urban setting. A comparative study can be done between urban and rural participants. A comparative study can be done between block and same district or between two or more districts. More intervention study required in different settings as it involves low cost. Same study can be done with improving other caregivers. Thank you.
Dr. Geeta Kumari, working as an associate professor in the Department of Kaumara Britya, Sri RMD Ayurveda College and Hospital, Gujarat, India. Today, I'm going to present on a clinical approach to Ayurvedic management of AARS2 leukoencephalopathy. First, we shall have an overview regarding the topic AARS2 leukoencephalopathy. It is a rare autosomal recessive neurodegenerative genetic disorder which mainly affects the brain's white matter. This is caused because of the mutation in the AARS2 gene which lead to the various neurological problems. Furthermore, we shall strive to get a comprehensive understanding regarding that topic. The term leukoencephalopathy, it includes any disorder which involve the white matter of central nervous system. This disorder, it results either from the mutation in the gene which are responsible for the synthesis of myelin, or maybe acquired manifestation of vascular, inflammatory, infectious, traumatic, toxic, nutritional or neoplastic diseases. Now we shall see what is AARS2 gene. AARS2 gene is a nuclear gene which encodes the mitochondria-specific alanine tRNA synthesis, which is very much important in the synthesis of protein within the mitochondria. Because of the mutation in this AARS2 gene, it disrupts the function of this enzyme, leading to the impairment in the protein synthesis within the mitochondria, which in turn lead to the deficiency of oxidative phosphorylation, ultimately affecting the cellular energy metabolism, thus contributing to the cell damage and oxidative stress. All these cellular dysfunction compromise with the ability of oligodendrocytes to produce and maintain the myelin, thus leading to the manifestation of the leukoencephalopathy with the abnormalities in white matter, structure and function of the white matter. Now we shall see about the symptom. The symptoms of leukoencephalopathy are varied, with predominant manifestation being the motor symptoms, that is cerebellar symptoms, that is ataxia, hypotonia, pyramidal signs like spasticity, weakness, brainstem involvement like dysphagia, dysarthria may be present. There may be spinal cord involvement in the form of bowel and bladder dysfunction. Leukoencephalopathy may present with the other neurological deficits such as seizures, optic atrophy, and peripheral neuropathy. And all affected female patients presents with the ovarian failure. Cognitive deficits are invariably present in the patient with the leukoencephalopathy associated with the features of frontal lobe dysfunction such as intellectual disability, learning difficulties, and behavioral changes. To diagnose the condition, initially it is important to identify the neurological deficit, which is done by the thorough clinical assessment, and then MRI scanning help in identifying the pathological changes in the brain. To arrive at a definite diagnosis, genetic testing is important, which will help in identifying the underlying molecular basis. So now we shall move on to the Ayurvedic perspective. According to Ayurveda, leukoencephalopathy can be understood under the heading of Vata Vyadhi. This Vata Vyadhi is a heterogeneous group of diseases which is caused because of the abnormal functioning of the Vata dosha. Among various manifestations of the vitiated Vata dosha, here I have mentioned few of them. whose symptoms are present in the leukoencephalopathy, such as sankocha, that is spasticity, contractures, pangu, that is motor deficits, angashosha, that is muscle wasting, spandana, movement disorder, griva hundana, postural disorder, akshepa, seizures, rajonasha, ovarian failure. And hence leukoencephalopathy can be understood as a type or variety of the vata vyadhi itself. So before going for the management of the disease, it is very much important to clinically classify the vata vyadhi, because according to the Ayurveda, the treatment is directed towards the dosha involved and underlying etiopathogenesis. So based on the dosha involved, vata vyadhi can be kevala vata, where only vata dosha is involved, or dosha samsishta, where vitiated vata is associated with the pitta, kapha, or both. Based on the etiopathogenesis, vata vyadhi can be caused because of the dhatukshaya, that is degeneration, or avarana, which can be understood as the obstruction to the vata dosha. So this is the general treatment principle of the vata vyadhi after consideration of involved dosha and underlying etiopathogenesis. In case of kevala or the shuddha vata, snehana or ovulation therapy remains the main cornerstone of the treatment. Snehana, it involves administration of the medicated oil or ghee. Snehana is always followed by the svedana or sudation therapy, which involves inducing the sweat to the patient. In case of Sansishta Vata, Mrudu Shodhana, it is a mild purificatory procedure like Virechana can be adopted. If the patient is unfit for the Mrudu Shodhana, then Niruha Basti, that is decoction enema, can be employed. If the patient is unfit even for the Niruha Basti, then Deepana Pachana, that is administration of internal medication which enhances the body metabolism, can be given. In case of Avarana type of pathology, Sroto Shodhana, that is cleansing the internal channels of the body, will be required. Along with that, Yapana Basti, which means mild decoction enema, and Mrudu Sansana, which means laxative therapy, are also has to be adopted. Along with that, Rasayana, that is rejuvenation therapy in the form of Gugulu, Shilajatu, can also be used as an adjuvant. In case of Dhatukshaya type of pathology, Brahmana line of treatment, that is tissue replenishment therapy, has to be employed. This is the general treatment principle of the Vata Vyadhi. But if we see the pathology of the leukoencephalopathy, according to Ayurveda, it can be understood as a Dhatukshaya leading to the vitiation of the doshas. So here, Brahmana, the primary intervention necessitates the Brahmana line of treatment. And in the further slides, as I'm going to present a case on the leukoencephalopathy in a child, which was managed through the Ayurvedic intervention, I am going to emphasize these Panchakarma therapies, especially in the children. So among various Brahmana therapies, one type is the Snehana, which can be given either internally or externally. External application of Snehana can be done in the form of Sarvanga Abhyanga, where we can see the first picture, which involves the full body massage with the medicated oil, which is tailored according to the specific ailments. Second is the Shirodhara, which involves slowly and steadily dripping the medicated oil or other medicated fluids over the forehead. Third and fourth is about the Shirobasti, which involves the retention of the medicated oil over the head for the stipulated period of time. The advantage of doing Snehana lies in its ability to replenish the degenerated tissues and thus providing the necessary nourishment to the children. It also helps in enhancing the strength and improving the body metabolism in the children. So this is the Svedana. Svedana can be done either Ruksha Sveda or Siddha Sveda. Ruksha Sveda, that is dry fermentation, and Siddha Sveda, which means wet fermentation. Here in the neurological diseases, Ruksha Sveda is not advisable as it further worsens the condition. So in case of neurological condition, it is always preferable to opt for the Snigdha Sveda. And Snigdha Sveda can be efficiently done with the procedure called Shashtikashali Pinda Sveda, which you can see in this picture. Shashtikashali Pinda Sveda is a procedure where which involves the application of the heat with the help of the potali prepared with the rice, processed with the medicated decoction and the milk. This is ideal in children because it has a nourishing property, and in the neurological disease, it will help in increasing the muscle bulk, muscle power, and also it helps in reducing the hypertonicity. And according to Charaka Samhita, a continuous application of Snehana and the Svedana help in reducing the stiffness and mobile contractures. Another important Panchakarma procedure which is indicated in the neurological disease is the Basti. Basti is considered as the best treatment for the Vata Vyadhi or neurological diseases, and also it is aimed as a nectar in children. According to Charaka, Basti is specifically indicated in the neurological diseases like gait abnormalities and all. Among various varieties of the Basti too, and it is play an important role in degenerative type of neurological diseases, that is Yapana Basti and the Matra Basti. Commonest form of Yapana Basti is a Mustadi Yapana Basti, which help in enhancing the muscle bulk. It improves the strength, and also it has a rasayana property. Then Matra Basti, it is a type of oil enema which can be given on daily basis, which is easily tolerated by the children. It do not cause any discomfort or complication to the child, and it also help in increasing the muscle strength in the child. Here, I would like to mention another important intervention practiced in the Ayurveda to enhance the cognitive abilities in the child. That is Swarna Prashana. Swarna Prashana, it involves administration of metallic gold, that is purified gold, in the minute quantities, along with the other memory boosting herbal drugs like Vacha Brahmi on every Pushya Nakshatra. This will help in enhancing the memory, improves the retention power and other cognitive abilities. Along with it, also improves the immunity of the child. And hence, Swarna Prashana has been included in the treatment of the neurological diseases to improve the brain functioning. Now, I am going to present the case on a 4-year-old case of leukoencephalopathy, which is managed with this Ayurvedic intervention. A 4-year-old male child presented with the involuntary movement of limb and head since the child was of 2 months old, associated with the global delay in the developmental milestone. The child was not able to speak or maintain the posture, and he has also not attained the control over the bowel and the bladder. He was the first child of non-consanguineous parentage. Antenatal history was uneventful. The child was delivered through spontaneous vaginal delivery at 37 weeks of gestation. There was a delay in the cry, and the child cried after the stimulation. On the first postnatal day, child developed with the involuntary movement all over the body. So he was admitted in the NICU where stabilization was achieved. On the second postnatal day, the baby was handed over to the mother and breastfeeding was initiated. Later, when the child was 2 months old, again child developed with the involuntary movements over the limbs and the head associated with nystagmus. As the child grew older, the parents observed there was a paucity in the play and global delay at the developmental milestone. Despite the child being under the conventional treatment for 4 years, he has shown no significant improvement in his condition. The child was under tablet adhesive 201 BD since he was of 4 months old. Syrup Valparin 2.5 ml TID and syrup Neutropil 5 ml TID since the child of 2 years old. And all these medications were stopped by the parents on their own as soon they started with the Ayurvedic medication. During the baseline assessment of the milestone, it was observed that there was a global delay in the developmental milestone in the child. In gross motor skills, even though the child was able to sit with support at the age of 3.5 years, sitting without support was not attained. In fine motor skills, the child was not able to approach the objects with one hand and 2 finger thumb grasp were not attained. In social and adaptive milestone, the child was not able to wave and do not respond when the name was called to. In the speech development, the child was not able to vocalize when spoken to. During the neurological examination, it was observed that the higher mental function of the child was subnormal, as demonstrated by the disorientation of the child to time and place, and global efficacy in the speech with very low IQ. And pyramidal signs there was spasticity was present, extensive plantar response and brisk tendon reflexes were present. Frontal release sign, that is positive clavicular tap. During the cerebellar examination, nystagmus, titubation, rebound phenomenon, intention tremor were present with positive dystrophic leukokinesia. In finger, nose, chest, past pointing was present. Truncal ataxia, gait ataxia were present, and tandem walking heel knee tests were not possible. According to gross motor function classification system, the child was at level 5 where the child was not able to move independently. He has to be carried to move from transport from one place to another. And the severity of ataxia was evaluated through the scale for assessment and rating of ataxia, where the score of patient was being 37 out of 40. MRI was done, which reveals absence of T1 hyperintense, T2 hypointense signal in bilateral centrum semivoval, pre-post central gyri, anterior posterior limb of internal capsule with presence of subtle hyperintensity in bilateral cerebellar white matter and marked thinning of corpus callosum. Genetic testing was done employing next generation sequencing, specifically clinical exome sequencing was done, which identified the pathogenic variant of ARS2 gene in exon 20, demonstrating autosomal recessive homozygous inheritance in the child. Impression of the report was combined oxidative phosphorylation deficiency, leukoencephalopathy, which is progressive in nature. So based on the MRI scanning and genetic testing, the child was diagnosed to be suffering from AARS2 related leukoencephalopathy. And according to Ayurveda, he was diagnosed to be suffering from Sarvanga Vata due to Bija dosha leading to Dhatukshaya causing the Vata Prakopa. This is how the child was treated in our hospital. Before going for the main line of treatment, initially Rukshana Karma was done, for which Udvartana, which involves full body powder massage with the powder of herbal drugs were done. Here for the same Kola Kulatadi Churna was used, and this Udvartana was done for 3 days. And after 3 days, this Udvartana was stopped and started with the Sarvanga Abhyanga with the Bala Ashwagandha Lakshadi Tela and Shishtikashali Pindasveda. Simultaneously, Kala Basti, it means a regimen of medicated enema where decoction enema and oil-based enema are given alternatively for 16 days. Here, for decoction enema, Mustadi Yapana Basti was used, and for oil-based enema, the mixture of Mahamashatela and Samvardhana Gruta was used. And then along with that, as the child was not able to have the involuntary movement over the head, initially Shirodhara with the Brahmi Tela was done. And after several months, when the child was able to hold the maintain the posture, it was switched to Shirobasti with the Brahmi Tela. And all these set of Panchakarma procedures were done regularly with an interval of 4 months for 3 consecutive years. Along with these Panchakarma procedures, internal medications like Sarasta Arishta with gold 2 ml BD after food, Swarna Prashana 2 drops BD before food, Kalyanaka Gruta and Samvardhana Gruta 10 ml BD before food, mixture of 2 pinch of Vacha Churna with 3 gram of Sarasa Churna mixed with the honey and applied over the tongue. Along with this, physiotherapy was also advised. So this is the result which was observed after the continuous treatment for 3 years. That is, involuntary movement of the limbs and head which was present previously was markedly reduced. Nystagmus was completely resolved. Speech, the child was able to comprehend and speak monosyllables. The coordination was also improved. Gross motor function classification system, the level of the child was improved from 5 to 3, where the child was able to walk with assistance, and the severity of ataxia was assessed, where the score of the patient being improved from 37 to 26 out of 40. And in the cognition, the child was able to follow the verbal command. This is the video of the child before treatment, where the child had a truncal ataxia. The child was not able to maintain the posture, and he is not able to stand with or without the support. So this is the video of the child showing after the treatment, after continuous 3 years of treatment, where in the gross motor skills, the child is able to sit with a stride, back stride, and he is able to climb up from the sitting position. He is able to stand without support for about 20 seconds. And in social and adaptive milestone, the child was able to wave and he was started responding to name, and he's also able to follow the instruction. In language and milestone, the child was able to vocalize and speak monosyllables. By these cross motor skills, we can understand that there was an improvement in the mobility, and also in the child has become a bit of independent. So this is the video. This is the video showing before treatment, the child had to be held with both the shoulders to make him walk for a shorter distance, and he has to be carried to move from one place to another. After the treatment, just with the minimal support, you can see the child is just holding the finger with the minimal support, he was able to walk. That indicates there was an improvement in the motor function. There was a minimal improvement in the motor function, and also it shows the quality of the life of child has been improved. Not only in the gross motor skills, but also in the fine motor skills, there was improvement in the fine motor skills, where we can see the child was able to approach the object in the one hand, and he was able to transfer the object from one hand to another. And there was also improvement in the crude finger, thumb, pincer grasp, where the child there was an improvement in the crude finger, thumb, pencil grasp, where the child was able to hold the finger, hold the pencil and imitate the scribbling. And he was also started self-feeding, and he was able to dress for some extent. So, thus concluding my presentation, ARS2 leukoencephalopathy is a rare genetic disorder. Being a genetic in origin, the complete remission of the disease is not expected. Hence, preserving the neural tissue and improving the quality of life and preventing the permanent disability becomes the primary object of the treatment. While treating the children, it is very much essential to consider the selection of drugs, dosage, and procedures according to the age. Panchakarma procedures are integral part of Ayurveda care for neurological diseases, and it should be used in multiple sessions and for a longer duration. In this case, Ayurvedic intervention along with the Panchakarma therapy definitely played a significant role in reversing the neurological deficit, and it also help in improving the quality of life. However, larger sample studies are needed to evaluate the efficacy of Ayurvedic intervention. Thank you. Once again, I would like to thank the Global Healthcare Congress for providing me this opportunity to present this huge platform. Thank you.
Good morning to one and all present here. I'm Akshra from Bhaskar Medical College, and I'm here to talk about Crohn's disease. Crohn's disease is an inflammatory bowel disease along with ulcerative colitis. It is a chronic granulomatous inflammatory disease that can affect any part of the intestine from mouth to anus, and terminal ileum being the most commonly affected area. Coming to the etiology, it has bimodal presentation.
Doctor, I'm sorry to interrupt your presentation, but could you turn on your camera as well?
Oh, I'm sorry, I didn't realize it was turned off.
Thank you.
Coming to the etiology, it shows bimodal age group, which is 15 to 30 years and 17 to 90 years. Appendectomy poses to be a risk factor for Crohn's disease and is protective against ulcerative colitis if it is done below the age of 20. Use of antibiotics in the first year of life also poses to be a risk factor. This disease runs in the family, and monozygotic twins are shown to have much more coincidence of having it than dizygotic twins. Smoking is also a risk factor, and it is 3 times more in smokers. It is also shown to have slight female predominance, as OCPs are used by females. Okay, it is also associated with von Eichel's disease, which is a glycogen storage disorder, and Turner syndrome, which is a sex-linked chromosomal disorder, and Hermansky-Pudlak syndrome. This syndrome has a triad of oculocutaneous albinism, increased platelet aggregation, and the prevalence, it is more prevalent in Jews and whites. There is slight female predominance, as I already mentioned, due to increased usage of OCPs. Smokers are shown to have 3 times more incidence, and it is more amongst 15 to 30 years of age. The classification was given by the Vienna classification, and it was done on the base on like considering 3 parameters. The 3 parameters are age of onset, location of the disease, and behavior of the disease. Age of onset gives it into 2 categories, that is A1 and A2. A1 showing below 40 and A2 showing above 40. Location of the disease is again divided into 4, which is L1, L2, L3, and L4. L1 being ileal, L2 being colonic, L3 being ileocolonic, and L4 being the upper GIT. Behavior of the disease is again divided into 3 categories, that is B1, B2, and B3. B1 being non-stricturing and non-penetrating, B2 being stricturing, and B3 being penetrating. Coming to the pathophysiology, as I already mentioned, there's evidence of both genetic and environmental components. So there's transmural or submucosal inflammation, and this is due to dysregulated mucosal immune response. So basically what happens is when a pathogen enters into the lumen, it is taken up by Th1 because there is overactivity of adaptive immunity and decreased innate immunity. And the mucosal barrier is actually the innate immunity, which is actually downregulated, and the adaptive immunity becomes active and it is directly taken up by Th1 cells. So there is also decreased production of defensins by Paneth cells. So if a person is genetically susceptible or if there are any environmental triggers, the bacteria or any infection that has been in the lumen, it is taken up by Th1, and this abnormal inflammatory response that leads to the release of TNF alpha and interleukins like 12 and 23. This leads to chronic granulomatous inflammation leading to tissue damage. There is strong association that is seen with bacterial dysbiosis. There is increased enterobacteriaceae and reduced firmicutes bacteroids. In this slide, you can see the pathogenesis. I'm sorry, just give me. Yeah, so here the impaired mucus layer, this is impaired because there's decreased innate immunity, and the bacteria, it directly enters and it is taken up by the dendritic cell, and Th1 is activated. This leads to release of interleukin 12, 23, and TNF alpha that leads to inflammation and damage to the tissue. Coming to the clinical features, they can be gastrointestinal, uh, extraintestinal, and systematic. The gastrointestinal symptoms include abdominal pain, diarrhea, which is non-bloody, in contrast to ulcerative colitis, which has bloody diarrhea. There's also flatulence, bloating, perianal discomfort. So a large bowel diarrhea usually is small volume feces with increased frequency. That's what is seen in colitis. And small bowel diarrhea has large volume and watery diarrhea. That is in ileitis. So in the mouth, there is non-healing aphthous ulcers, glossitis, and angular stomitis. Um, you can visually see the aphthous ulcers in the mouth if the Crohn's disease present in the mouth. The patient also complains of dysphagia. Coming to the systemic manifestations, growth retardation is seen in 30% of the children. This is because of malabsorption. Older people, there is weight loss due to reduced food intake. The adults generally take lesser food as they tend to have diarrhea after eating or abdominal pain, which makes them reduce the amount they're eating, and it causes weight loss. If small intestine is extensively involved, there's malabsorption of fat, protein, and vitamins that leads to weight loss in older people and growth retardation in children. Coming to the extraintestinal manifestations, there is joint, ophthalmic, and skin manifestations. The joint manifestations are ankylosing spondylitis, which is inflammation of the spine, and there is very much pain in the spine. There is peripheral arthritis, which presents as large joint migratory asymmetrical articular arthritis, which involves the knees and hips, and small joint migratory asymmetrical polyarthritis that involves the toes and fingers. The small joint arthritis is associated with uveitis. The ophthalmic manifestations are episcleritis and uveitis, and skin presents as erythema nodosum, which is red patches on the skin, and pyoderma gangrenosum, which is a necrotic debris that is formed on the skin, which is very much painful too. The other clinical manifestations are calcium oxalate stones in the kidney. This is because of increased absorption of calcium oxalate from the intestine. The patient also presents with thromboembolism, or it is associated with non-Hodgkin's lymphoma. The complications include bowel obstruction. This might be because of stricture formation. And there is toxic megacolon, which is one of the most important complication. In this, the intestine dilates, and there is a lot of distension, and the bowel becomes stagnant, and it is a very painful condition. There can be fissures or strictures. As I told you, strictures also cause bowel obstruction. There'll be jejunoileitis. Fistulas are formed. Fistulas are either intravesical or perianal, and intravesical are more common. This can be seen where the feces comes out in the urine as the fistula is formed between the intestine and the bladder. There's also liver abscess, portal or mesenteric vein thrombosis, and perforation if there's an ulcer formation. The differential diagnosis is Behçet's disease, which is the most important differential diagnosis. This is because it has many common presentations as Crohn's, which include the age of onset, the gastrointestinal symptoms, the spondyloarthritis, along with diarrhea, abdominal pain. And the other differential diagnoses are inflammatory diarrhea, in which the patient has inflammation like that include pain along with diarrhea. And celiac disease, which also has diarrhea and malabsorption. Intestinal tuberculosis, it is said that intestinal tuberculosis is almost always confused with Crohn's. And if it's a Crohn's now, can always turn into, can always maybe diagnosed as intestinal tuberculosis later. Graft versus host disease and diverticulitis. Coming to the management is of two parts, diagnosis and treatment. Coming to the diagnosis, CT is more preferred to endoscopy. This is because on endoscopy, you cannot completely reach to the small intestine, and on colonoscopy, it just comes to the colon and not the terminal ileum. So the radiology is always preferred. On endoscopy, you can see aphthoid ulcers, cobblestone appearance, and string sign. Cobblestone appearance is due to the inflammation that looks like cobblestones with fissures in the middle. Um, and in the first picture, you can see that there are stricture formation. And on radiology, you can see aphthoid ulcers, Crohn ulcers, and string sign. To observe the string sign, the patient is given a barium meal, and then the radiology is taken. Because of stricture formation, you can see in the second picture, the barium swallow only occupies some portion of it, as the other part is strictured, and it looks like a string. So this is called a string sign. And garden hose appearance. Coming to the treatment, recurrence is very common, so remission can only be delayed with medication, and it has no proper permanent cure. In mild to moderate cases, oral budesonide is given, and moderate to severe cases, uh, steroid, which is budesonide, with methotrexate, and anti-TNF alpha drugs are given. The anti-TNF alpha drugs are infliximab and adalimumab. For maintenance, low-dose methotrexate is given along with azathioprine or 6-mercaptopurine. Severe to very severe cases, intravenous steroid is given along with intravenous anti-TNF alpha drugs. And for maintenance, low-dose anti-TNF alpha drugs are given. Thank you so much for patiently listening to me, and I hope I was clear enough. And I'm ready to answer any questions if anyone has any queries.
Good afternoon, everyone. My name is Joshita, and I'm currently a final year medical student here at Danilo Halitsky Lviv National Medical University. And today I'm here to share a few words on Upadacitinib in Crohn's disease, a comprehensive systematic review of its efficacy and safety. As you all know that Akshara has already shared a few words on Crohn's disease, I will now be speaking about the effect that Upadacitinib as a drug has on the course of this disease. If you have any questions, I'll be really happy to answer them at the end of this presentation. Okay, can we go to the next slide, please? Thank you. Before we delve into this topic, I'd just like to share a few words on Crohn's disease itself. It's an inflammatory bowel disorder that's going to affect any part of the GI, beginning from the mouth to the anus. But as we know that it's going to affect mainly the intestinal part. On this slide, I've also shared an image that shows or states three common sites of intestinal involvement in Crohn's disease, with the ileocolic or the terminal ileum part of the GI being the most commonly affected part. And while the cause of this disease is exactly unknown, however, several advancements have been made to treat this disease. And this review is going to provide a very in-depth examination of Upadacitinib, a novel Janus kinase inhibitor, its performance considering the efficacy and safety in managing Crohn's disease symptoms, and it's going to also offer a valuable insight on the potential role that Upadacitinib is going to prove as a treatment option. Next slide, please. So we conducted a thorough analysis of the existing evidence in order to gain a very comprehensive understanding that the drug has a potential in order to prove as a therapeutic approach. So through our research, we discovered that it possesses a remarkable ability to effectively regulate the levels of inflammation present in the infected area, thereby reducing the severity and symptoms associated with this disease. And moreover, our findings also suggest that it can modify the disease natural course of the disease by slowing down the progression and ultimately improving the patient's life and patient's quality of life. Next slide, please. So I'd like to discuss the components of the systematic review. Starting from this slide, the primary aim of our systematic review was to assess the safety and efficacy of Upadacitinib in the treatment of Crohn's disease, and as well as to gain any insights regarding the effects that the drug has, as well as to pay attention to the adverse effects of it. To ensure that a comprehensive review has been made, a systematic exploration of all the electronic databases such as PubMed, Embase, and Cochrane Library were performed using, and we use specific keywords and the mesh terms that related specifically to Upadacitinib and Crohn's disease. Next slide, please. So we included all the studies that range from 2013 to 2023, and we further supplemented the search with scanning gray literature sources, conference proceedings, and reference lists that included studies to capture any potentially overlooked relevant researches. And so after screening about 103 articles, 3 publications were issued in the study. Included in the study, and they mainly consisted of 2 RCTs and 1 prospective cohort. And studies that did not report any kind of relevant data were excluded. Next slide, please. So now talking about data extraction and quality assessment were performed by 2 individuals, and these individuals worked independently, conducting the tasks in a very standardized manner to ensure thoroughness and reliability. So all this extracted data encompassed all the various aspects, including study details, participant demographics, intervention details, and also assessed outcomes, so that this meticulous process was conducted to allow a comprehensive analysis of all the gathered information. Next slide, please. I'd also like to mention that our systematic review strictly follows the PRISMA guidelines, and such rigorous measures were taken to mitigate any kind of potential biases. After a thorough comprehensive search, 3 studies meeting the inclusion criteria were identified as mentioned priorly, and these selected studies encompassed various designs, including RCTs and a cohort study, and these mainly spanned from 2020 to 2023. Next slide, please. In this slide, I've included an image from our systematic review itself that actually shows how we scanned all these articles and narrowed them down to all the reports that were included in our systematic review. Next slide, please. Now I'd like to discuss the results. The efficacy of Upadacitinib in Crohn's disease was the central focus of the selected studies. And so within the RCTs, we could observe that significant enhancements in clinical remission were observed in patients receiving Upadacitinib as compared to those simply in a control group. And the 3 studies were reported with very notable improvements in the endoscopic remission following the treatment with this drug, which is also another pivotal parameter which was evaluated across the selected studies. Next slide, please. So several studies have consistently shown that Upadacitinib therapy provides long-term benefits in Crohn's disease management by reducing the mucosal inflammation over extended follow-up periods. And these selected studies ultimately have shown significant interest in assessing the potential risks and adverse effects that Upadacitinib can have. And I'd like to report the few adverse effects that were reported by these patients. These mainly included infections with herpes zoster and intestinal perforations, non-melanoma skin cancers, and cardiovascular events, as well as anemia. Next slide, please. However, with these adverse effects included, there were instances of very serious adverse effects necessitating treatment cessation were reported in 3 studies, which is going to highlight that it's very important to safely monitor the protocols and to ensure the well-being of the patients before they undergo therapy with Upadacitinib. And in this slide, I've also included an image from our systematic review again, which shows the adverse effects that the patients have faced during the treatment with Upadacitinib. Next slide, please. Now I'd like to discuss the key findings from this systematic review. The review findings are going to contribute significantly to Crohn's disease treatment protocols, and the clinical trials achieved remission in moderate to severe cases with Upadacitinib. The evidence also suggests that the drug tends to induce endoscopic remission clearly on rather than clearly just clinical remission. However, it's important to emphasize the individuality of each patient's case and the need for personalized treatment. This is because every patient has a different type of case presentation, and so because of it, they can present with different adverse effects and symptoms. So it's going to be very crucial for us to significantly pay attention towards the safety of this drug. Next slide, please. And finally, conclusion. In conclusion, the systematic review on Upadacitinib and its selective inhibition of JAK pathways aligns with the observed clinical improvements, suggesting a targeted approach to modulating Crohn's disease pathophysiology. It has shown promise in improving clinical remission rates as well as endoscopic outcomes, addressing the underlying inflammation and promoting mucosal healing, particularly beneficial for non-responsive patients. Next slide, please. Although Upadacitinib has shown a potential for treating certain medical conditions, it's also important to consider all the various factors before prescribing to a patient. These factors include a patient's medical history, the patient's preferences, and potential comorbidities that a patient might have. And such considerations are very crucial to ensure that the best possible treatment outcomes are achieved and to minimize the risk of adverse reactions in any patient. Despite such limitations, the study heterogeneity and potential biases, future research should also focus on robust long-term randomized control trials to establish sustained efficacy and safety in Crohn's disease. And Upadacitinib is a promising addition to Crohn's disease treatment, and it's offering hope for improved management and quality of life in patients. And continued research and clinical experience would further refine its role in personalized treatment of Crohn's disease. Next slide. Thank you very much. I hope that you all like my presentation, and I'm really happy to answer any questions that you have.
Everyone, I'm Dr. Chira Clementina. I am a medical graduate from India. I've done my MBBS in Government Medical College Nizamabad, and currently
I'm doing my master's in health sciences in the United States. And today I'm going to talk a little bit about KRAS as a prognostic and predictive marker in metastatic non-small cell cancer. All right. So this presentation aims to investigate the impact of KRAS mutations on metastatic non-small cell lung cancer based on a systematic review. Let's talk a little bit about the background of KRAS mutations and what exactly KRAS is. KRAS proteins belong to the RAS protein family, and they are small GTPases derived from the KRAS gene located on the short arm of chromosome 12. Through alternative splicing, this gene can produce two distinct proteins, weighing around 21 kilodaltons each, KRAS4A and KRAS4B. The most common KRAS mutation occurs when a single DNA base is substituted, resulting in amino acid substitution at positions 12, 13, 61 of KRAS protein. Once activated, the KRAS protein disrupts the normal cycle and proliferation. This persistent activation of KRAS leads to activation of downstream signaling pathways such as MAPK and MI3K, which are crucial for regulating cell division, survival, and differentiation. So when all these pathways get disrupted, there's uncontrolled cell division and development of cancer. Non-small cell lung cancer represents the predominant type of lung cancer, constituting approximately 85% of diagnosed cases. Compared to small cell lung cancer, non-small cell lung cancer often exhibits a slower progression and dissemination. Non-small cell lung cancer manifests primarily in three histological subtypes that are adenocarcinomas, squamous cell carcinomas, and giant cell carcinomas. Let's go into the importance of this study. Metastatic non-small cell lung cancer poses a significant clinical challenge, prompting a focused investigation into the role of KRAS mutations in prognosis and treatment response. Targeted therapies offering promising avenues for intervention, motivating a comprehensive analysis of existing evidence. Now, I would like to talk a little bit about the methodology used in the study. It was conducted in June 2023. Our review delved into Medline, MBase, Scopus, and Cochrane Register of Controlled Trials. Rigorous inclusion and exclusion criteria guided the selection of 12 articles from a pool of 120 articles, which comprised of 2 randomized controlled trials and 10 observational studies. Multiple investigators independently excluded data extraction, evaluating prognostic factors and predictive outcomes. And now I would like to talk a little bit about the quality assessment. So for the quality assessment, we use the Newcastle-Ottawa scale, NOS, and modified JDAD ratings were employed to evaluate the quality of the studies. NOS assesses observational study quality by considering the selection of study cohorts, their comparability, and the assignment of the outcome of interest. On the other hand, JDAD score appraises the quality of randomized controlled trials by scrutinizing their descriptions of randomization methods, blinding procedures, and management of participant withdrawal or dropout. Let's talk a little bit of how the KRAS status was assessed. The KRAS status of the study participants was established through various methodologies, such as PCR, polymerase chain reaction-based assays, and direct sequencing of DNA genomes. Additional techniques were employed to encompass paraffin section DNA extraction, qualitative PCR, and next-generation sequencing. KRAS as a predictive marker. So how do we talk about, how do we consider KRAS as a predictive marker? The studies show that the patients with KRAS wild type demonstrated a better response to platinum-based chemotherapy. Conversely, patients with KRAS of mutation type showed better response to ICIs, which is immunotherapy based targets, but it had inferior outcomes towards chemotherapy. So that's how we could show that KRAS as a predictive marker. KRAS as a prognostic marker. KRAS mutations have been shown to alter the prognosis of metastatic non-small cell lung cancer. Patients with KRAS mutations manifested worse overall survival and progression-free survival than those of the wild-type KRAS. Now let's talk about the geographic context and KRAS mutation effects. Understanding the consequences of KRAS mutation requires consideration of regional environment. Like every other disease, there is a regional component to component. So studies undertaken in various countries helped to a better knowledge of KRAS mutations in non-small cell lung cancer. For example, a Danish single-center prospective clinical trial sought to assess the predictive relevance of KRAS mutation at various stages of non-small cell lung cancer. Their thorough research found that individuals with KRAS mutations had worse treatment response rates than the shorter PFS than those with wild-type KRAS tumors. What was the treatment response? Various treatment responses were seen in the investigations. Patients with different KRAS mutations developed varying responses to various therapies. Patients with KRAS mutations, for instance, outpowered those with wild-type KRAS in terms of overall survival and progression-free survival when treated with immune checkpoint inhibitors, like pembrolizumab. What would be the survival rates? Survival rates reported in the research varied, especially since KRAS mutations impacted, as I've already said, both the overall survival and progression-free survival in patients with non-small cell lung cancer. Numerous studies reveal that patients with wild-type KRAS tumors had a longer median overall survival and a tendency toward better median progression-free survival than those with KRAS mutations. Nevertheless, others found no significant changes in OS or PFS, comparing individuals with wild-type and mutant KRAS. So there are a lot of variations in this study regarding survival rates. Risk of bias assessment was again done based on Newcastle-Ottawa scale for observational studies and modified shaded scores for randomized control studies. The NOS evaluates the quality of research based on study groups chosen, their comparability, and the determination of the result of interest. The JRAS score, on the other hand, evaluates the quality of randomized control trials based on their description of randomization, blinding, withdrawal, and dropout procedures. Conclusion. The review's key findings are described with implications for prognosis and management of metastatic non-small cell lung cancer considered. The necessity for more studies to cement KRAS prognostic significance and investigate the effectiveness of KRAS inhibitors and other therapeutic is highlighted. As a result, this will open the door for more precise and individualized therapies in the treatment of metastatic non-small cell lung cancer. So that's about it. I hope my presentation was effective and we learned something new today. Thank you.
Each and every place do have their social problems that they do experience at their current moment. So the study conducted looked at the damage caused by COVID-19 among young people in South Africa. So if we look into those three things, which is poverty, suicide, 19, so there are multiple agent social issues confronting citizens in African countries. So these include, but not limited to, poverty, suicide, and COVID-19, as like I said, that we do have like the social problems that are different from place to place. So poverty is inherently associated with food insecurity among social vulnerable people with limited access to nutrition and safe food, which includes South Africa as well, because we do experience poverty, and other African countries, they still do experience poverty. And approximately 460 million Africans live below the poverty dentam line. So COVID-19 arrived in 2020, as we all have seen that, and exacerbated the poverty impacting mental health with increasing record suicide. So a lot of people, obviously, because we had to adapt to the new normal, which is COVID-19 for those past 2 years, if I'm not mistaken. So obviously, because adjusting to new things might in a way affect the way we adjust to things and may increase our mental health issues. So poverty, suicide, and COVID-19, it's a triangular, which we can say it is like sort of a vicious cycle. But we will see that as we move forward as to why do I say it is sort of a vicious cycle, because each and everything links to one another. So looking at COVID-19 impacted on the standard of living and quality of life, behavior, and social interactions. So the safety regulations attempted to reduce the spread of COVID-19. So there are a lot of safety regulations that were implemented to try and, reduce the spread of the COVID-19, and economies was decimated. So companies were retrenched. Companies retrenched employees. So a lot of people here in South Africa were retrenched because a lot of companies escaped liquidation, while others, they did close down. So unemployment intensified poverty because people lost their job, and obviously they couldn't have anything to bring into the table. Hence, poverty rate went up. So COVID-19 had an equally devastating impact on self-employed persons, and we do call those people the street vendors, of which a lot of people here in South Africa, they do make living from being street vendors, meaning that they sell whatever they're selling in the street without having their own business that is standing there. So they usually sell things to make end meet. So as estimated number of people who lost jobs was approximately 20 million in 2020, and research depicts that unemployment rate is extremely high among young people. So when we're looking into unemployment, it has been reported that 72% of unemployed young people with university qualification, they display symptoms of depression. And this is where the mental health enters, because I did mention earlier on that everything links to one another. So in 2021, unemployment rate among the young people rose to 63.9%, and 99.3% of university graduates were unemployed, and others were seeking employment. And in 2020, the rate dropped down by a marginal 2.9% documented to 61%. And if we're looking into the current statistics, currently it has dropped down to 45.5% among young people from the age of 15 to 34. So in as much as it does show that it has been an improvement when it comes to unemployment and everything like that, it's not much of a difference, because a lot of people are still unemployed, and we're still experiencing people who are not working, and poverty is still in a higher rate. So moving forward, this is just a structure which explains how COVID-19 is linked to all of these things. So if we're looking into COVID-19 here, this sign here, it shows here that obviously there were implementations that were done, like your safety regulations that we should do social distancing, and there was lockdown. We had to isolate ourselves from other people, just to prevent the spread of the virus, and also we had to quarantine. However, all of those factors, they had an impact because being isolated, obviously, it makes one to be, you know, a bit attached to other people. And we obviously had fear of COVID-19 infection. So everyone had everything going in their mind because we had fear of like dying and everything. And we saw our loved ones dying in front of our eyes because of COVID-19, and uncertainty as well as bottomness. So if we move from here to this structure that is on my right-hand side. So here it shows the impact of all of those things, whereby people starting to had changes in eating and sleeping patterns and behavioral issues, and domestic violence, of which domestic violence is one of the things that drastically increased in South Africa during the COVID-19, even though it was always there, but it went a bit higher during the pandemic. And obviously, this includes all the mental health issues people were going through. So people suffered anxiety, stress, loneliness, frustration, worry, feeling of helplessness, depression, as well as post-traumatic stress disorder, which is PTSD. And this also includes the one that is on the second to last, which is relapse of pre-existing health disorders, because obviously people were still trying to adjust to the new norm, if I can put it like that, and others, for them to cope, or using the coping mechanism, they decided to like use alcohol consumption as well as drugs, just to make sure that they just suppress the emotions, suppress their thoughts with this entire thing that was going on, and as well as suicide. So other people, obviously, who couldn't take a lot of pressure, they decided to either commit completely or attempted suicide. So moving forward, here we are looking at COVID-19 and mental health issues. So this is like a sort of a literature review, the scholars. So the lack of knowledge about mental health issues is a predicament in low and middle income countries compared to the well-developed countries. I'm sorry. So I do know that a lot of people are aware of this, especially in the African countries. This includes South Africa as well. In as much as we do know that there is mental health issues, but I feel like information is not spread enough for people to know about the mental health issues, because people who live in the cities and in townships, yes, they are aware of that, even though knowledge is not like in a broader format. But people who live in the rural areas are still left behind, because a lot of things, they take time to reach them, and they do not have access to a lot of things. So remote working and study increase pressure, distress, and anxiety, trying to prove productivity to the authority. So this happened obviously during the pandemic, whereby people were working from home because we couldn't go to our workplaces. So they had to make sure that they put in the work to submit whatever deadlines that are required from them. So obviously the environment of working from home and working in your workplace, it wouldn't be the same, because now you have to pressure yourself, you have to take care of the family, you have to attend to the household things at the same time. So obviously people, you know, they went through a lot of things like pressure, distress, and anxiety. And moving forward to the third bullet, which is shortage of staff, limited health facilities, public and self-stigma are factors that restrict the general community from seeking professional help. So this goes back to the first bullet that I talked about, because in South Africa, we do have, yes, health facilities, but there are those people who do not have access to those health facilities. So we have such a shortage of health practitioners. We have limited health facilities, hence people cannot go and seek professional help, as well as the stigma, because I myself, I grew up in a rural area, and people still believe that if you're having like mental health issues, you are perhaps crazy, or you are perhaps going through the things that need that, like rituals, like cultural things, or ancestors. So such things, they do hinder people to like seek professional help. And patients are being discharged to limited space without being fully rehabilitated. So this goes back to us having limited health facilities. So people are unable to get the help that they need, or to be fully rehabilitated, due to the fact that there will be other people who are still coming in, and we do not have like enough or sufficient facilities or equipment to accommodate all the people. And then moving forward, the third to last bullet, this has to do with the coping mechanism people opted to. So young people, it shows here that young people use the following as coping mechanisms. So people started reading books, exercising, while others were consuming alcohol, which I did mention earlier on, eating, isolating, and suicide as the last resort. So I'm pretty sure we all had some of the things that we did here, just to make sure that we just disattach ourselves from being stressed and everything like that. And moving on to the second to last, which is excessive alcohol consumption cause memory disorder, dilemma, and delusion. So allowing people to take impulsive decisions, such as committing suicide. So we all know that a lot of or should I say excessive alcohol consumption obviously will damage the brain in a way, and will eventually cause these three things that I've just mentioned here. And it will obviously make one to make an impulsive decision, even though it's not like everyone, but it does in a way cause such things. And then lastly, which is the social media usage increased drastically as a coping mechanism during the pandemic, which could permit also cyberbullying and exacerbate suicide. So I do attest to the social media increase drastically high, because TikTok was one of the things that actually went viral during the COVID-19, and I must say it did help in a way, even though some of the things it didn't like make a good impact on it, because obviously people were cyberbullied and everything like that, and it has been found that it can also lead to suicide, obviously, because the things that are being said, other people cannot like take it in and move on with the flow. So I'm just gonna proceed from here then and look into suicide. So with suicide, it is a global social health challenge, and it is one of the leading causes of unnatural deaths. So approximately 800,000 cases are reported per annum. And the mental health, which is depression, is rooted to in biology, psychological, social, clinical, and environmental factors. So suicide is controlled by the country's economy. So when the country is, when the economy is vulnerable, suicide rate will increase. So obviously this leads back to what I did mention earlier on, to say if obviously unemployment rate did increase, and if people are unemployed, they will eventually suffer into like a lot of distress. And they may, some will commit suicide, some may attempt suicide, even though it's not going to be everyone who does the same thing. And this is the continuation of the COVID-19 and what happened during the COVID-19. So adjusting to the new norm exposed mental challenges during the pandemic, and this left communities vulnerable. And studies indicated symptomatic depression increased among unemployed youth graduate. So depression, it is associated with suicidal ideation as well as the suicide itself. So safety regulations and lockdown increased gender-based violence among women and children, of which I did mention when we started the presentation, that gender-based violence is one of the things that drastically increased in South Africa during the pandemic. And within the systematical patriarchal context, when men are socially, so they are socially socialized into being strong and strong aggression and roles. So we all know that how men have been socialized to be those strong people who do not show emotions and being providers and everything like that. So with the COVID-19 coming into place, people losing their jobs, and they also lost sense of being men, and they couldn't provide for their families. So inability to provide financially, expression of vulnerability, and fear of emotions increased the number of gender-based violence. So all those emotions that they had, they then made them to the perpetrators of gender-based violence. So the victims of gender-based violence are obviously prone to depression and suicide, because we all know that if people are suffering from, or if they are the victims of gender-based violence, they will eventually have mental health issues, of which it has been explained here, that such as depression, and it might also lead to suicide if they can no longer take in what they are going through. So moving on to the findings. So depression and anxiety are one of the illnesses that affected young people during the pandemic. And this is due to job loss, that of our loved ones, as well as academic pressure. So gender-based violence increased drastically during the pandemic due to high level of stress and high alcohol consumption. So men suffer from imbalanced mental health issues due to bottling things up. Hence, suicide rate, it is higher among men compared to women. So the stats did show that suicide rate, it is greater in men compared to women, particularly in South Africa. So people who mostly attempt suicide suffer from the mental health issues. So moving on to the clinical model, or should I say the things that I think they may they may fix the issue, even though not completely, but the issues that we are currently facing. So in South Africa, to be specific, we have a rule, if I can say, or a policy whereby a lot of companies, they do not employ people who do not have experience. So I feel like if they were to create a no experience job, then that might increase the number of people who get employment and everything like that. Because I feel like it's a bit unfair for people who come from who just graduated and everything like that, who obviously do not have experience, and they found themselves trying to apply, but they're not being taken because they do not have experience. So if they were to create maybe a room for those people to say, okay, here is a no job experience that you guys can apply to, then that could maybe decrease the number of the rate of the unemployment, and they will eventually see a less rate when it comes to high rates of mental health issues. And moving forward to entrepreneurship from high school should be taught in a broader format. So a lot of people have decided to gravitate to having their own businesses, because it has been seen as if going to school, it's a waste of time, because we are studying, but yet we do not have jobs, or rather we are not employed. So if they were to teach people then in a broader format about how to conduct a business, how to have your own business, each and every skill and techniques that they business, I think it might be a better option. And also if the government were to look into subsidizing people's companies, and that can eventually create jobs for people that are unemployed. And also looking into the age restriction should be extended for people to be employed. So I don't know about other countries, but here in South Africa, we have an issue whereby when you are getting employed, you should be from the age of 18 until the age of 35, of which I feel like it's a bit unrealistic, because there are people which will have their life unfolding maybe around the age of 36 going upwards. So having to say you're trying to apply for a job application, and now you cannot apply, or you're not going to be taken, or they're not going to accept your application due to the fact that you're no longer within the age group that they're looking for. So I feel like it's a bit unfair and a bit realistic. Hence, we have a lot of unemployment rates and high rates when it comes to the mental health issues. And coming to the two things that I feel like they are mostly important for me, it has to be the mental health awareness, because I did mention that we have people who do lack information when it comes to mental health issues, because we have this tendency to think that it is more of white people issue than the Black people issue. So people tend to confuse things if they need to be dealt medically or to be dealt culturally, because if one was to have whatever sort of mental health issues, it can tend to be confused with something that has to be like a ritual thing, because they would say maybe you should be going through things that needs ancestors and everything like that, only to find out that if you were to seek medical help, things may unfold in a better way. So I feel like if people were to be taught, not shying away from being Africans and everything like that, but if people were to be taught about the mental health issues, and if they were to find themselves in that situation, so that they can be able at least to do it both ways, maybe seek medical medical help, as well as seeking the cultural things into overcoming whatever situation that they are facing at that time. And then lastly, which is the medical health centers should be available in clinics for accessibility. So this one goes back to those who are staying in the rural areas, to be specific, because I feel like people who are staying in the villages, or rather in the rural areas, they do not have accessibility when it comes to mental health centers or facilities. So because you'd find that the clinics are too far, they do not have hospitals close by. Hospitals or clinics are in towns, and going there is a struggle for them. And if they are there, there are shortage of practitioners, the healthcare practitioners, and you find that there is like only one doctor, or the doctor comes at a certain time, and when they do arrive there, sometimes there wouldn't be anyone to attend to. So I feel like if they were to pay much attention to that, and make sure that each and every place does have medical practitioners that are needed, then we might try to overcome the mental health issues that people are going through. So thank you very much for your attention and listening to my presentation. I hope it was informative. And if there are any questions, I would like to take them. Thank you.
Sarah Soran from Iraq, Erbil, and I have PhD in food science, food microbiology. My research title about the ultrastructure and molecular characterization of Sarcocystis species.
Sorry to interrupt you, but could you put your presentation on full screen?
Just 1 minute. Now it's okay, please?
Yes, it's okay. Thank you.
It's okay?
Yes, it's okay, doctor. You can start.
Okay. And sorry for late because I have little mistakes in the net connection. That's why. My research PhD titles about the ultrastructure and molecular characterization of Sarcocystis species isolated from domestic sheep and goats in Soran, Erbil, Iraq. Now going to introduction. Sarcocystis species are cyst-forming coccidian intracellular protozoan parasite of the genus that belongs to the family Sarcocystidae or phylum Apicomplexa. Sarcocyst species causing sarcostosis, which are responsible for the formation of cysts, often observed in the skeletal and cardiac muscle. It has a high prevalence in sheep and goats, resulting in serious injury in different organ systems, portion, and death. Approximately 200 wild species of sarcosis have been described, which vary in their pathogenicity. For the host, some species are zoonotic. However, complete life cycle are known just for 26 of them. Several sarcosis species infect sheep and goats, some of them transmitted by cats and other by cat. Some species from microscopic sarcosis, other from macroscopic. We have two types, microscope and macroscope. Sarcosis in the muscle, including in sheep, Sarcosis gigantea and Sarcosis mudiciforum produce macroscopic sarcosis, and Sarcosis tenila cause microscopic cyst. Now going to species infected in goats. Sarcosis hurricanes and Sarcosis capricanus appear as a microscope sarcocyst, where Sarcosis muli forms macroscopic cyst. Aim of this study. Meat is one of the main dishes in Iraq. The health of meat source, sheep and goats, is significant. Sarcosis species, in fact, are widely spreading in animals in Kurdistan region, Iraq, with no molecular and ultrastructure diagnostic test available. Therefore, the current study aims to investigate the prevalence of Sarcosis species, especially the species of macroscopic sarcosis which infect this animal in Soran Erbil, using molecular and ultrastructure diagnostic methods to affected esophagus and of sheep and goat. To characterize the macroscopic sarcosis of both studies animal ultrastructure via scanning electron microscopy and transmission electron microscopy. To identify the species of the isolated macroscopic sarcosis molecularly by PCR, polymer chain reaction, sequencing, and phylogenetic analysis. Life cycle of sarcosis species of small ruminant, asexual stage and sexual stage. Its asexual state is found only in the intermediate host, which is mostly a pre-animal. Infect begins when sarcocyst, oocyst, or sporocyst from feces of the final host are ingested by this animal. Sexual stage, meaning the final host acquires the infection by the ingesting mature sarcocyst within the muscle of infected animal. Material and methods. 1,000 esophagus sample from 400 sheep and 600 goats were collected during August 2018 to August 2019, confirmed by first examination, gross examined muscle and pepsin digestion, then examined by histological, macroscopic sarcosis and confirmed esophageal tissue. Then scanning electron microscope and light microscope. Molecular aspect, macroscopic sarcosis, DNA extraction, and PCR and phylogenetic tree. All histological sections of light and electron microscope were examined to characterize the sarcosis species using 4 different primers. First, primers primer 2L forward and primer 3H reverse, and amplicon size equal to 815 base pair. Second primer and third and fourth. Primers for PCR and sequencing for Sarcocystis species using 18S rRNA gene to detect Sarcocystis species from sheep and goat in Erbil and Soran state. In this slide shows the result and discussion. Prevalence of microscopic Sarcocystis species in esophagus of domestic sheep and goat. Animal species, sheep and goat. Number of examined, 400, while in goats, 600. Number of infected parasitic disease, Sarcocystis species, 38, while in goats, 53. Prevalence of Sarcocystis species among male and female of domestic sheep and goats. In sheep, number of infected, 35, while in goat, 8 in males. Females, results shows 3% and number if infected 45%. It differs. Here we have different shapes of Sarcocystis infected in esophagus. Gross appearance of microscopic Sarcocystis in the esophagus of the inspected sheep and goat with bradyzoid. Microscopic Sarcocystis in histological section of sheep and goats. Histopathological changes in esophageal tissue of infected sheep and goats with microscopic Sarcocystis. Here, SEM, scanning electron microscopy, examine 2 Sarcocystis. Image shows microscopic Sarcocystis of 3 species. First, Sarcocystis mudiciforum, Sarcocystis mollis, Sarcocystis gigantea. High magnification of macroscopic Sarcocystis of Sarcocystis mudiciforum. Here we have septa, bradyzoid, and cell wall. Longitudinal and cross-section of bradyzoid Sarcocystis species by TEM, transmission electron microscope, shows the composition of the bradyzoid. Polymer chain reaction products of partial 18S RNA genome Sarcocystis species presented bands at first primer 1050 base pair and second 815 base pair and third one 619 base pair and 1517 base pair on 1% of agarose gel. We have all positive results of the band for detection Sarcocystis species, molecular detection. Now going to phylogenetic tree of selected Sarcocystis species by the program MEGA version 7 using maximum likelihood based on 18S RNA gene sequence. Here we have clade 1, 2, 3, and 4, 5. All species of Sarcocystis, we have similarity with another Sarcocystis including in Iran or Syria or in Jordan or in another country. Here we have phylogenetic tree of Sarcocystis species. And after phylogenetic tree, recorded this gene in gene bank with new species detected in Iraq Erbil. Conclusion: domestic sheep and goats destined for human consumption in Soran were infected with macroscopic and microscopic Sarcocystis of different Sarcocystis species, both of them infected with Sarcocystis. All sheep and goats that were infected with microscopic sarcosis were observed to be infected with microscopic sarcosis. Pepsin digestion method seemed to be more sensitive and faster than other methods for detecting microscopic with infected animal carcass. The high prevalence of microscopic sarcosis species in Soran animal reflected a significant role played by stray dogs rather than cats in its transmission. Genotypic characterization provide that all isolates of microscopic sarcosis were carrying 18S rRNA gene and were amplified in all positive samples, yielded the expected amplicon PCR for different primer using for detecting sarcosis. Recent findings demonstrated that the isolated sarcosis species were most closely related to Species 1, Sarcocystis gigantea, Sarcocystis molli, and Sarcocystis midiciforum, and may consider them as sibling strains. Cross-infection may happen among sheep and goats. Therefore, the host specificity of several Sarcosis species is questionable. Phylogenetic analysis results inferred from the genetic markers indicate the microscopic Sarcosis species were within the group of Sarcosis species, with filling as now for predictive definitive host. Finally, this is the first time that the microscopic Sarcosis of Sarcosis species have been demonstrated in the sheep and goats, characterized by polymer chain reaction based molecular and ultrastructure using transmission electron microscope and scanning electron microscope for detecting Sarcosis species in esophageal, in sheep and goats in the Kurdistan region in Iran. Now going to recommendation. Further investigation with more specific gene markers like the mitochondrial flux gene and the ITS1 sequence is recommended to differentiate the closely related species. Experimental transmission investigation with the proposed definitive host are required to confirm the characters of the host range of Sarcosis species. For possible public health hazards evaluation, larger number of animal and other Sarcosis infected organs needed to be screened. Studies that focus on the presence of infection in humans are essential for a better understanding of the zoonotic risk of Sarcosis species infected. A butter ruminant must be burned to break a life cycle between intermediate and definitive host of this parasite. Further study should concentrate upon the reproductive and economic effects of parasitic infection in both these small ruminants. That's all. If you have any question, I am ready to answer it. And sorry for late. Thanks for all staff in this conference to make this best connection with my best regards. Thank you for listening.
21st century discoveries in the physiology of adaptation and dramatic changes in the validation of substance dependence. Summary. The article shows that the current level of physiology does not disclose the biological mechanisms of the organism transition from one range to adapt to a higher with an increase in the regular forces of the stimulus above subextremia. New trend in the physiology of adaptation. Progredients adaptation explains the mechanism of increasing the tolerance of the organism with dependence on psychoactive substances POS. It is scientifically proved that dependencies of the organism on POS, not the disease, and the states like progredient progressive adaptation. Urgency of the issue. It is known that at the peak of dependence on any psychoactive substance, a person, for example, an opium heroin addict, uses doses which are multiple times, almost 10 times, higher than the lethal dose for an ordinary percent. Fact that the drug user does not die is explained by the increase in the body's tolerance in response to the increase in the dose of PARs. Urgent issues of medicine are not only identification of mechanisms for increasing tolerance, but also validation of the physiological process occurring on exposure to increasing doses of a psychoactive substance and the response increase in tolerance of a PARs-dependent organism's purpose and objectives of the study adaptation reactions of the organism with regular exposure to a sub-extreme stimulus, lack of adaptive reactions of the organism already known in modern physiology to explain the adaptation mechanisms in response to a further increase in the regular stimulus strength above the sub-extreme level. In PARs-dependent patients, vegetative nervous system reactions, pronounced reactions from the vegetative nervous system VNS when exposed to a psychoactive substances, indicate the vegetotropy of most of these substances. The magnitude of the force of their impact is closest to subextremal, with regular exposure to some kind of irritant under the influence of sub-extreme stimuli. An activation reaction with the stages of primary and persistent activation occurs, indicating a higher activity of protective systems. The stage of persistent activation is a true active resistance, stable, lasting, in contrast to the training reaction, and in the absence of constant exposure for a long time, up to 6 months, but with dependence on psychoactive substances. The process does not end with a persistent activation reaction. The dose to which adaptation has occurred is habitual, does not give a euphoric effect. To obtain a neurophysiological shift sufficient for euphoria, an increase in the dose is necessary. Increasing the dose of psychoactive substances after an activation reaction is stressful. 1L. K.H. Garkavy and co-authors, 1977, showed that the reactivity of the organism is represented by a number of flaws ranges, and there are no more than 10 of them. 2. In each, a weak stimulus causes a training reaction, an average sub-extreme one, an activation reaction, a strong one, stress. 3. LKH. Garkavy et al. Did not explain the mechanisms that provide, with a further increase in the force of influence above the stress one, the transition of the body, bypassing exhaustion and death, from one level of reactivity to a higher one. Mechanisms of adaptation reactivity. According to pathophysiology, without the presence of such adaptive mechanisms that increase resistance, the body must die from exhaustion, from the breakdown of adaptive mechanisms. When the body passes from the first range of adaptation to the second, but when the body is dependent on psychoactive substances, this is not observed. This shows that the current level of physiology does not explain the mechanisms that provide the body with the transition from one range of adaptation reactivity to a higher one. Increase in tolerance. Changes leading to an increase in tolerance with dependence on PARs can only be adaptive and not pathological, damaging in nature. Otherwise they would not lead to an increase in tolerance, but, on the contrary, would lead to its decrease and the body would die, already during the transition from the first stage of adaptation to the second. Also, according to the dialectical principle of the mutual transition of qualitative changes into quantitative ones, The accumulation of these changes should lead to qualitative and quantitative changes in the system responsible for the adaptation of the organism as a whole, the neuroendocrine system.
I.N. Payetnitskaya, 1988. It is known that no less important than maintaining homeostasis than biochemical protection are holistic functional responses to the intoxication of physiological systems. Therefore, we can talk about changing the body's response to the drug. Object and methods of research. Features of the reaction of the neuroendocrine system to any external stimulus. The ability of the endocrine system to positive trophic changes. Hypertrophy and hyperproductivity of the endocrine system. Histological and biochemical evidence. Heat tension of the neuroendocrine system and the reaction of persistent activation cannot explain the transition from low to a higher range of adaptation with an increase in the strength of PA exposure to stress and above stress. After all, the body then must experience stress, exhaustion and death. This can only be explained by the enhanced functioning of the neuroendocrine system, which is possible only with its physiological adaptive hypertrophy, in response to the regular impact of an external factor. It is known that due to trophic irritation in a working organ, the process of assimilation begins to prevail over the process of dissimilation and morphological changes occur in a physiological way. Object and methods of research. 1. An increase in energy reserves leads to an increase in efficiency. 2. In the functioning of the neuroendocrine system, there is an evolutionary mechanism that contributes to the accumulation of reserves. Anticipatory excitation, described in the 30s of the last century by P. K. Anokin. 3. The autonomic, vegetative, nervous system, ANS, responds to any stimulus with a somewhat excessive neurotransmitter release, as if in anticipation of possible future high costs. The ANS, through neurotransmitters, includes auxiliary and tissue adaptation mechanisms, and due to the excess neurotransmitter release, it takes a break for its own recovery, trophic processes. But, despite the recovery, trophic processes, the ANS cannot hypertrophy. The adrenal medulla is a modified sympathetic ganglion. But adaptive, positive, trophic changes, during pauses, allow the sympathetic ANS not to be depleted, to maintain high activity for a long time, a kind of hyperfunctionality. But there is no doubt that the mechanism of anticipatory excitation is also characteristic of the endocrine part of the neuroendocrine system, when the endocrine glands, releasing excessive hormones, also take a break for their own trophic recovery processes, but unlike the ANS, these processes lead them to hypertrophy and hyperproductivity. After all, hypertrophy is the lot of structures. Histological evidence of physiological hypertrophy of the endocrine system with regular exposure to a medium-strength stimulus is Cellier's research on the stress reaction the adrenal glands bloom. Speaking of adrenal hypertrophy, one must keep in mind the cortical layer of the adrenal glands. Back in the 30s, it was found that chronic morphinization causes hypertrophy of the cortical layer of the adrenal glands of rats, which produces adaptation hormones glucocorticoids, hydrocortisone, cortisone and corticosterone, which increase the body's resistance to strong stimuli.
Research results and discussion. Thus, with regular exposure to psychoactive substances, an irritant of subextreme magnitude, when hypermetabolic processes occur in the metabolic boiler, in the endocrine system, due to anticipatory excitation, an accumulation of reserves occurs, leading to its adaptive physiological hypertrophy and hyperproductivity, which leads to an increase in the body's tolerance, therefore, a subsequent, increasing, potentially extreme dose of psychoactive substances. Processes in the endocrine system. Thus, with dependence on PAS, in each range, and the transition to a higher range of adaptation, one should not talk about a reaction dyad, activation and persistent activation, but about a reaction tetrahedron, activation, persistent activation, then stress, with an alarm reaction, and the stage of resistance, but with dependence on psychoactive substances. The hypertrophy of the endocrine system that has come to this point does not allow the final stages of stress, exhaustion. With an increase in the dose of psychoactive substances, and the transition to another range, everything repeats, etc. Such a process, with a regular, gradual increase in the acting dose of PAS, should not be called a state of constant, chronic stress, but should be called a state of regular incomplete stress. Stress, no matter how regular it is, without the final stage of exhaustion, does not lead to pathology. This process, the authors of this scientific work named, progressive adaptation. Thus, adaptive capabilities grow in direct proportion to the increase in dose, and the role of receptors of the body's protective systems is also important, which signal a possible overdose on PAS, the experience of anesthesia. Therefore, all acquired biological changes with dependence on PAS are only adaptive and, as a result, we must talk about adaptive craving, adaptively changed behavior, adaptively changed reactivity to psychoactive substances, or, conversely, about readaptation, deprivation syndrome, and so on. In the final stage of dependence, the depletion of the body's adaptive capabilities due to hypertrophy of the endocrine system, the receptors of protective systems signal a possible overdose of psychoactive substances, which leads to a parallel decrease in the dose of psychoactive substances that a person is able to use. The strength of the effect of psychoactive substances again turns out to be sub-extreme. No pathology is again observed. Pathology in dependence on psychoactive substances, a concomitant phenomenon. The compensatory tension of the ANS and sufficient production of neurotransmitters or residual neurotransmitter excess explains adrenergic tension and pronounced autonomic disorders during readaptation, alcohol deprivation syndrome. The activity of the sympathetic part of the ANS against the background of the gradual depletion of the parasympathetic department, the adrenergic system is more stable in ontogeny, also explains the qualitative change, as the narcotic addiction lasts, of the effects of sedative-acting PAS, hypnotics, alcohol, opiates, on the body, the transformation of their initial sedative action in the stimulus. With the development of dependence on psychoactive substances due to the mechanism of anticipatory excitation, which contributes to adaptive activity, hyperfunctionality of the sympathetic ANS, physiological hypertrophy and hyperproductivity of the endocrine system, the role of the neuroendocrine system as a whole, as a functional mechanism of protection and adaptation, becomes leading. Conclusions. 1. With regular sub-extreme effects on the body of psychoactive substances, the mechanism of anticipatory excitation allows you to maintain the activity of the sympathetic/autonomic, vegetative, nervous system/ANS, leads to physiological hypertrophy of the adrenal cortex. Two, with regular subextreme exposure to a psychoactive substance, adaptive preservation of the activity of the sympathetic ANS and adaptive hypertrophic changes in the endocrine system, adrenal cortex, lead to an increase in body tolerance. 3. Independence on psychoactive substances. Due to the adaptive activity of the sympathetic ANS, adaptive hypertrophy and hyperproductivity of the endocrine system, potentially extreme doses have a subextreme, non-pathogenic effect on the body. 4. The dependence of the body on psychoactive substances, due to the increase in the body's tolerance and the transformation of the impact of potentially extreme doses into subextreme, is an adaptive process. Recommendations. It is necessary to validate the dependence of the organism on psychoactive substances not as a disease, but as a state of progressive adaptation.